I think that it's important for, especially the fellows and the younger physicians. Unfortunately, our history has sort of shied away from intradiscal therapies. And we were talking about it early this morning at 6 a.m., Doug, Brian, Tyler, and myself. And we're very risk averse in our field, and that's good, right? We want to keep our patients safe, but there have been some really interesting movements. One is paralysis and strokes from cervical transforaminal epidural steroid injections, and we've really moved away from that as a field, but there are still spine surgeons who would like to know that information for the surgeries that they're going to do, which impose certain risks, of course, to their patients. And so I personally do those types of injections all the time. And then intradiscal therapies, because we've had some incidents of discitis that have obviously been difficult to manage, that's really moved our field in a different direction. And of course, some of the outcomes from some of the previous therapies, IDET, et cetera, didn't go as well as we would have liked. But a lot of those issues aren't necessarily the therapy itself, it's patient selection. And so what we're talking about here, the anterior elements, are very important if you're doing interventional spine, because quite frankly, spine surgeons don't really want to deal with anterior element disease. They want to deal with the intraspinal and maybe some of the other issues surrounding the spine. But if it comes to a disc or the vertebrae, that's really where we can intervene. Unless there's, of course, instability of the spine, then they have to, of course, create stability. So what you heard from Doug was really about the intradiscal therapeutics, really exciting time in our field. I've jumped on the VIA disc study that we're doing right now, but that was based on the early information from the VAST trial, which Doug just showed you, and so I'm very excited about what the future holds. Now we're going to shift gears to a different way of addressing this kind of pain, and there's some similarities and some differences. So raise your hand if you do genicular nerve blocks or radiofrequency ablation. And for what joint are we doing those procedures? The knee. And you just heard Doug sticking needles in the lumbar disc, a joint. Now we're going to shift gears to actually intervening on the nerves that innervate the joint. So that's sort of the same analogy. The genicular blocks or radiofrequency ablation to the knee joint, or diarthroidal joints, and then the basivertebral nerve as the source of innervation to the lumbar intervertebral disc. So I'm going to talk about some of the exciting basic science that has really come out with this particular therapy. And really a lot of it actually applies to some of the intradiscal work that Doug just described. So I think that's probably the best part of working with this company is the work with Dr. Lotz, and I'll show you a little bit of that in just a second. So this is just an overview slide of what we're going to go through in the next 18 minutes here, and that is really talking about the degenerative cascade of the lumbar intervertebral disc and what happens over time. Number two, the identification of that pain signal through the basivertebral nerve. There are also inputs through the sympathetic fibers and the sinovertebral nerve as well. But this intervention really focuses on this particular nerve, which, as you can see in the lower left, is a nerve that comes in through the posterior border of the vertebral body, goes to about the 30 to 50% mark, and then arborizes both cephalad and caudad. And really, if we can ablate or neural lyse that nerve right at the trunk of that tree, if you will, then we can see potentially some long-term results. And we'll show you those outstanding outcomes in just a bit. The procedure itself is really a combination of two therapies. Number one, kyphoplasty. So if you're familiar with pedicular access, this is straightforward. There's some slight nuances as far as your angle of approach, but basically it's the same idea. And then the second concept being radiofrequency ablation, which you heard about earlier from Dr. Beal. This uses bipolar radiofrequency ablation to create the lesion. So basically what you're creating is about a 1 centimeter in diameter spherical lesion right at the trunk of that basivertebral nerve, as you see on that image there in the middle right. And on the bottom right, as I'll show you, the outcomes are phenomenal. We not only have one level 1 study, but 2 level 1 studies and 2 multi-center studies in which they've shown significant improvements in chronic low back pain related to the vertebrae or vertebrogenic pain. And one of the questions you might ask, and we'll probably talk about this in our discussion, is how do you compare discogenic pain and vertebrogenic pain? And the way I see it, both are very similar in presentation as far as your patients, anterior column pain, pain with flexion, pain with sitting, but really it's on the spectrum of time. So that discogenic pain probably is an earlier issue, as Doug alluded to. These patients are generally younger, and vertebrogenic pain being pain that lasts for a longer period of time. Now, where that dividing line is remains to be determined, whether that's 6 months, 12 months, 24 months. But in general, these are the patients who have the 5 years, the 8 years, the 15 years of chronic low back pain. The average length of time these patients in the SMART trial, which is their level 1 study, which I'll show you the results of, the average length of time they had chronic low back pain was 6.7 years. And so these are the patients who have really struggled to find any therapy to help them out. And that's why I'm really happy to work with this particular therapy. So you know the problem. We get older, there's trauma, the discs degenerate, and what we see radiographically are end plate microfractures. The disc bone interface starts to weaken. Doug already showed you some of those images from the MRIs, and you see the discs become darker. You start to see the inflammatory response, and that results in Modic changes, Mike Modic, radiologist. And then the question was, what do we do about it? We see these patients with chronic low back pain. And as I just alluded to, we now have something that actually can address that. So we look at Modic changes as a biomarker. And there have been a lot of studies over the last 20 years regarding whether Modic changes are associated with symptoms. And certainly there are critical studies regarding that, but there have been a lot of positive studies that show that there is a relationship, whether you look at the odds ratio or the likelihood ratio of seeing these radiologic findings and then correlating that to the patient's presentation. And so here are some of the sources for looking at chronic low back pain, innervation of the end plates, and the greater risk for a poor outcome when you see those Modic changes. So, before this particular therapy, we would talk about Modic changes, and we'd see them and we'd identify them, but there really wasn't much we could do about them. And so what I tended to see over the last several years were radiology reports that didn't even describe Modic changes, even though they were clear as day on the MRIs. And why? Because it wasn't really relevant to us, because there was this back and forth about its importance. But now I'm telling my radiologists, hey guys, please comment on Modic, because again, it's going to alter the therapeutic algorithm for that patient. And then histologically, we do see with Modic type 1, this fibrovascular granulation tissue, and then Modic 2, why you see the bright signal on T1 and T2 is the adipose replacements, and then the end plate damage with both, and then the high bone turnover. So those are the histological foundational changes that are occurring, and what that results in are Modic type 1 or 2 changes. And again, if you're not as familiar, this quadrant here on the upper right is something you could copy and laminate and put on your computer screens just to remind yourself what Modic type 1 is, hypointense in T1, hyperintense in T2, and then Modic type 2 is hyperintense in T1, hyperintense in T2. So that's just an easy way to remember. And that's what we're looking for. Modic type 3 changes are when you see hypointense findings surrounding the disc on both T1 and T2. Those are not the candidates for this therapy. Okay, so a lot of, when you see the Modic type 1 and type 2, that's a generally more newer finding. At Modic type 3, that disc is really burned out, and it's hard to say if there would be any benefit from some of these therapies. So Jeff Loetz he's from UCSF, and has done just some outstanding work regarding the degeneration of the lumbar disc. And a lot of his work is this histological work, as you can see here. And as you zoom in and you look at the fibrocartilaginous structure, you see the tears. We all talk about the annular tears. We see the loss of the nucleus pulposus. But what we're really interested in is what is happening at that disc to bone interface, which is generally a really finite surface when we're 12 years old and 16 years old. But as we know, as we get into our 20s and 30s, for whatever reason, whether genetics, epigenetics, or trauma, you start to see that interface break down. And that begins the cycle where we start to see the radiographic findings of that disc becoming darker, the height being lost, and then eventually, potentially all the way up to Fearing grade 8 and then autofusion, which we see in some of our geriatric patients. So, zooming in on some of the work that Jeff has done, we see the end plate as really the paradigm shift in how we think about the disc, not the disc itself. What is happening at the vertebral end plates? And as you can see in slide C at the very top, there's that very nice barrier. And that's, again, what we see in some of our younger patients or patients who do not have any degeneration of their disc. And then in slide D, what you see is the interface, the melding, the blurring of that line. And that's really where you start to see the permeability and some of the nutritional and inflammatory markers. And you can see that here in slide E, where you have the tendril of inflammatory cells going in through the matrix. And the way we think about this from left to right is that you have this biomechanical strength, non-porous interface, and then over time with degeneration, you start to see that permeability and it becomes thin and porous. And that's really where you might start to see some of the inflammatory markers, and of course, the patients who are presenting to you with pain that's unremitting to lots of different interventions. So there are lots of different forms of end plate change from a histological perspective. It'd be great if we could get these kind of slides on our patients, but obviously our patients are living, so we have to wait until after they expire. But radiologically, we can see some of these correlates here. Looking at Jeff's work, one of the things he's really interested in right now are tight mark avulsions, as far as is that a potential specific biomarker to some of the chronic low back pain we see. We see erosions, we see the change in the permeability, the porousness of the end plates. Fractures are everywhere. We see especially in early disc degeneration. Schmorl's nodes are very common finding, important to differentiate between degenerative versus congenital, which you can determine under radiography. And then, of course, you've seen, of course, these situations where there's a herniation or depressurization, and sometimes the radiologists report that as an end plate fracture, when in fact that's really a degenerative change. But it's a blurred line. So all of these histological findings are what we're seeing with disc degeneration over time, and that, again, is demonstrating that the end plate is really an important source for where this pain is coming from. One of the old myths was that as the discs degenerate, the nerves grow into the disc, and that's what sends the pain signals. And really, that is not the case. We've looked histologically within the disc, and there aren't nerves in the disc. Where the nerves really do increase their fibrous density is at the end plate, at the interface between the disc and the end plate. And so that's a really important point here. And again, for me, when I was learning this stuff just in the last 4 years, it totally changed the way I learned about it in med school. It totally changed the way I thought about it, even early in my interventional spine career. So I hope this is doing the same thing for you, because a lot of these thoughts I had were assumptions based on some of the older work. But the idea here from Jeff is that the nerves don't grow into the disc. It's really the end plates that become more highly innervated. So we start to think about why this all happens. As I mentioned, genetics, epigenetics, and epigenetics are a really blossoming field right now, looking at the way that certain environmental factors affect the histones, the compounds that may change the structure of the DNA, which then changes the outcomes, the RNA, the proteins that come about. And so some of the work that's been done at UCSF with my colleague, Dr. Guan, was looking at how steroids epidurally may change the epigenetics, and that might be one of the reasons that steroids work when we use them for radicular pain, not just the anti-inflammatory effect, because if it was an anti-inflammatory effect, steroids would work from day one. But as you guys know, it sometimes takes 3, 5, 7 days. So why do we see that change slowly over time? Is it really from the anti-inflammatory effect, or is it really an epigenetic change? So that is, again, a real important blossoming field of science we're looking at right now. We are fully aware of all the inflammatory cytokines, chemokines in the lower left. That's why we prescribe NSAIDs for our patients for this situation. And then there's been work on whether certain types of bacteria infections may play a role in this. As you guys know, in the last 10, 15 years, there have been studies looking at certain antibiotics for these situations, certain bacteria like P. acnes, et cetera. That hasn't really fleshed out as much as we'd like. But again, all of these theories are kind of being put together as far as why discs degenerate. So this is a single slide on the outcomes. In my opinion, this is the best cadre of evidence in our interventional spine field. As I mentioned, we have 2 level 1 studies. One is a sham-controlled study. We don't have sham control and many other things in our world, so it's really awesome that a company decided to do a sham control study and then follow those patients out to 5 years. That's the SMART 5 trial. The Intercept trial was a therapy versus conservative medical management study. So how does it compare to doing physical therapy, epidural steroid injections, et cetera? That was the Intercept trial. That study was halted because the Data Safety Monitoring Board felt that the conservative medical management arm was unethical to continue. So they opened up all the patients to the therapy because it would be unethical to keep those patients suffering. That's the only time I've really heard about that in an interventional pain study. We hear about that with cancer drugs. We hear about that with HIV drugs when the therapy is so much better than the comparator. That's amazing. That is amazing that that was done. And when those patients crossed over, The recent Smook article proved that those patients had just as good of an outcome even with a crossover. And then we have, of course, other multi-center studies as well. And you can see that the same sort of L-shaped curve where patients get improvement with a reduction of their pain, and I'll show you some of the quartiles as I showed you in the first slide. And the same can be said of their ODI. So as Doug mentioned, when 20 points is an entire category, and what we've seen here is that generally patients are going to improve in their function by at least one category with this particular therapy. One important point to make is that when you do this particular therapy, the results are not instantaneous. They take weeks and sometimes months. So one of the important things I do is I show patients that data on the left-hand side. They assume that first data point is like really soon. That first data point is 3 months. So you really need to ensure that the patients have the right expectations regarding this therapy. But what's really remarkable is look at the 5-year data point. It's even better than the 2-year data point. It's better than all of the other data points. So there tends to be this continued improvement over time. Where are we right now with payers and reimbursements? Number one, they have their own ICD-10 code that was opened on October of 2021, M54.51. This is for vertebrogenic low back pain. So that is very specific. That is associated with pain with flexion and with Modic Changes. The CPT codes were then introduced January 1st of this year, 64628 and 64629, again, consistent with the 646 categorization of RFA. And so CMS has been improving this since January 1st. And now what we're starting to see are all of the commercial payers falling down like dominoes. And this has been a remarkable thing to see over the last few months. I read a lot of letters. I speak to directors for all sorts of therapies, this being one of them. And what I say to them is, anytime I've introduced another therapy, they're always like, well, I need another study. I need another study. This company came out and said, here are 2 level 1 studies, 2 multi-center studies, and then, of course, our early work with the case controls. And it's real-world stuff. And we have a registry, and also they came to the payers with everything. And if a payer said, no, we're not going to cover it, then that's on them. That's on them. What more can you ask for? How much money they've spent, doing the right thing, getting the therapy across the finish line. So we should continue to see in the next year and 2 other payers start to really not only cover, but reimburse us appropriately for a therapy that really can obviate a lot of other therapies, including drugs, which, as we know, have a lot of side effects, and not just opioids, but even our NSAIDs increase our cardiovascular adverse event risk. So I think the next step is looking at cost-effectiveness data. How do we identify these patients? It's really about the history. How do these patients, usually you'll see them not even sitting in your clinic room, right? Because they don't want to sit down. It's too painful. They're standing, they're walking around. These are patients who say that driving is painful for them, that working, over the pandemic and Zoom, doing Zoom in computer chairs is painful for them. So really pain with flexion or putting shoes on, putting socks on. And then, the second is to rule out other pain generators. As we know, the spine is complex. There are many different pain generators. Do the physical exam to rule out facetogenic causes, sacroiliac joint causes, intraspinal causes, et cetera. And then look at the imaging. And if all those other pain generators have been ruled out, you have pain with flexion, and you find Modic Changes, you now have a potential candidate for this therapy. So, of course, per the IFU, rule out your conservative care first, but most of the patients who present to me have already done the conservative care, the PT, the NSAIDs, et cetera. And so by the time I see them, I'm generally introducing this therapy on day 1, and we're moving forward. So the algorithm is pretty simple. Anterior column pain, Modic Changes can lead to basivertebral nerve RFA. This is indicated for levels L3 through S1. Our hope in the future is to extend that to rostral levels. As I mentioned, we have the Intercept 24 publication, 2-year outcomes. And just as an identifying factor, since Doug mentioned the sustained hip flexion midline versus off midline pain, 70% of patients who presented in that trial had midline axial back pain. So one of the ways to differentiate between SI joint, facet joint versus discogenic, vertebrogenic is to look at midline versus lateral or off midline pain. In general, if that patient has midline pain right across the spinous processes, you're thinking more discogenic, vertebrogenic. And as I mentioned, 80% of patients reported pain with flexion, sitting forward flexion, and position changes. So not 100% of patients, guys. You will find patients who are perfect candidates for this who have pain with extension, who do have right-sided pain or left-sided pain. So these are just numbers to help you get started, but you will eventually find patients who don't meet that rubric perfectly, and you may need to consider these therapies if you find that kind of patient. And as I mentioned, driving, tying your shoes. So this is, again, showing you the algorithm in a simple way. To me, from soup to nuts, this therapy works perfectly. We have a lot of these patients out there. It doesn't interfere with a lot of other therapies. In general, the intradiscal therapeutics we're considering earlier algorithm, but there are going to be some patients that may benefit from both, and we're going to find over time which is the right one to do when, and that's where we need the evidence and the data. So with that, I want to thank you for your time and attention. Are there any questions regarding basivertebral nerve radiofrequency ablation? You seem like you're going to ask a question, so. Do you want to give him a microphone, Glenn? Yeah. Sorry.
How many levels are you doing now? And there's a patient now thinking about, we're starting to do this at UVA, and they've got 2, 3, 3, 4, 4, 5, 5, 1.
Yep.
And seems like a bit much. How do you go about triaging the levels?
Yeah, so quite frankly, you do what's right for the patient. So if they have 4 vertebral bodies with modic changes, you're right. Other than doing a functional anesthetic discogram as potentially a diagnostic measure, which is not required but could be helpful in this situation. The flip side is if you bypass that diagnostic test, what's the harm in doing 4 levels versus trying to just do 2 levels? And really what we have not seen, and I should mention from the 5-year SMART trial, are consequences from doing this therapy, right? So does that lesion somehow weaken the vertebral body and maybe puts them at risk for vertebral compression fracture? We have not seen that because we've monitored those patients out longer. We haven't seen any long-term sequelae from the therapy. So that's why in that situation, I would just go to 4 levels. Yes, it's longer in the OR. And I think I can talk about this right now. So in 2 weeks, I'm going to have the opportunity to test a shorter lesion time. So there's going to be 2 options. One is a targeted lesion versus the standard lesion or the lesion we've been doing it, the way we've been doing it. And that's going to be your decision. So if your nitinol J-tip gets boom right on the trunk of the BVN, then you can do the small lesion, the targeted lesion. If you feel like, oh, I'm a little bit off center, whatever else, I'm not posterior enough, then you can do the larger lesion to catch more of that nerve. So that's going to help shorten OR times. But right now, if I'm doing a 2-level single disc, I've got that right now at 39 minutes, 40 minutes. 2 discs, 3 levels, I've got at 55 minutes, and then a 4th, another 15, 16 minutes. Because as one lesion is happening, I'm accessing the next, so you're bouncing back and forth. But I think with the targeted lesion, which I'll be able to trial the week of May 15th, I'm hoping we get that down to a 30-minute case for a single disc and 2 levels, but we'll see. I can't guarantee that every time I'm going to have a targeted lesion.
Yeah, excellent. Well, excellent presentation. When doing the procedure, obviously you have to worry about the posterior elements and the thermal effects from that. Is there a certain points that you're looking at to make sure you're staying safe, and for the audience and people online, how to keep themselves safe in doing this procedure? Because as you're saying, it's quite an effective procedure and it can help a lot of patients with chronic low back pain. And what do you look for when you're doing the procedure to making sure that you're keeping away from those elements?
Yeah, the only real safety concern with this therapy is pedicular access, RU2 medial. That's it. Just stay away from the river and you'll be good. There are different approaches. I mean, as Doug will tell you, you can go through the pedicle, you can go extrapedicular. And then once you have your access to the vertebral body, then it's really understanding the geometry. So you have this nitinol J-tip stylet that curves around. Your access is really, your pedicular access is really what sets you up for success. So that has to be good and safe. But there are some things you can do with that nitinol J-tip stylet to get you to that target appropriately. Frankly, once you're in the bone, you're safe. I mean, it's really just about getting to the nerve where you want. It's about the efficacy, but the safety deal is just getting across the river. And once you're there, you're good to go. So as I mentioned, if you're off that trunk a little bit in the lower left-hand corner, that's when the larger lesion may be helpful. You know, as far as long-term complications from the RF, it's still a question in my mind. We just haven't seen that from the data from the SMART 5. Is there something like, you know, some harm to the basivertebral artery or vein that might affect the nutrition of the bone? Maybe, quite frankly. I can't say, I know the answer to that. I don't know the answer to that. But it doesn't, denervate a muscle like the medial branches do. And that lesion, what's really interesting, is something that will be picked up on MRIs for quite a while, at least a year, if not two, maybe longer. And so it's important that if you start doing this to let your radiologist know, because if they've never seen this or are aware of this, they're like, is this a tumor? What the heck is that? There's a spherical lit up lesion in the middle of the vertebral body. So again, really important. I think most radiologists these days are very familiar with this therapy, and they're very excited about it because they're like, we've been looking at that nerve, but no one's doing anything about it. So thanks. But just important, again, depending on your community, to let them know.
Excellent.
I think just to piggyback on your question, what is the distance from the posterior wall? Sorry. Just to piggyback off the last question, what is the distance from the posterior wall that you're getting concerned of it spreading more posterior and maybe getting some of the descending?
So if you're less than 10 millimeters from the posterior wall, that's where the company has a concern about whether that RF lesion is too close to the posterior wall and therefore the thecal sac or the anterior epidural space. This is me speaking, not the company or the IFU. This is a bipolar lesion. And so even if you were inside the cortex of the posterior wall, that bipolar lesion is going to be cooled by the circulation of the anterior epidural space and CSF. And so you're not going to be able to burn the epidural space or the CSF, okay? So 10 millimeters by the IFU, the instructions is the safe zone, or to be anterior to that. But just between you and me, even if you were to be like at 8 millimeters and 9 millimeters, I'm not worried with a bipolar lesion there. What we're really aiming for is 30 to 50% across the vertebral body. And I'll just move away from the mic. So if this is our line, our equator, ideally we're right there, 30% of the trunk of the tree. I think there was one more question. Yes.
Is anyone studying using this technique at the time of a fusion, like doing the basivertebral nerve ablation intraoperatively before placement of a pedicle screw? I imagine that might be helpful because we have some of these patients that have like really long-standing low back pain, and we operate on them, and we may get their radiculopathy better. We may even get their back pain better. But some of these patients, you're seeing them 5-6 years later, and their MRI and their CT looks perfect, and they're miserable. So I'm wondering, is anyone trying to look at whether or not we could do this in the OR or immediately preoperatively and give these guys a hand?
This is an awesome question. We're talking about this right now. So the advisory board for the company is like 50-50 spine surgeons and interventional pain physicians from various specialties. And this is exactly right. I mean, you have an unstable spine, you do the right thing as a surgeon, everything looks perfect. The patient says, I have low back pain. And you're like, what are you talking about? I had everything perfectly, and everything looks great radiologically, et cetera. But then you kind of look at those Modic changes there, and you're like, oh, shoot. So I work in an orthopedic practice. I have 2 spine surgeons I work with. They are sending me patients who have completed a fusion, and they're saying, well, they've got vertebrogenic pain, either at the level they fused at or adjacent level that might have preceded or come up afterwards. And in 2 situations, those surgeons removed the hardware to enable me to come back and do this particular therapy because they felt that at that point, the stability had accrued and they didn't, need the hardware to be in place any longer. And I only need one side to access. So if, they wanted to somehow leave one side still, with the rod fused and allow me to get into the other side of the pedicle, I could do it that way, or I could do an extrapedicular approach, getting outside of where the pedicle screw is and that is absolutely possible. The reason I didn't do that is because L5S1 is a little hard to do extrapedicular, a little dangerous with the L5 nerve root. So that was not going to be my first rodeo. I wasn't going to let it be, at least. But at other levels, I'd have no problem doing that. So great question. I think that, I always love the idea of RF to precede a surgery, whether it's for the knees, the hips, the shoulders, and the discs. Let's do a study. That's awesome.
Excellent. That was a great question. Well,